no gut reactions to this, because we see this a lot. People come in and they're like, oh my God, I'm terrified about this patient. I'm taking them off opiates as fast as I can. And then you get patients who are desperate, calling the hospital, panicking, and in the worst cases, I mean, like, yeah, literally killing themselves because they're in such horrible withdrawal. And there's been horrible case examples of that. So just because this says, don't be comfortable going above these very easily as you're starting a new patient doesn't mean immediately take everybody down there. Other piece that I would point out, this was their dose recommendations were based on these, which are findings from a bunch of observational studies. And what these look at is the risk of an overdose event amongst people who are on different doses of opiates. And I know that this looks like a dose response curve that you would see in a pharmaceutical company. That is not what this is. This is naturalistic data of patients who get more than 100 milligrams a day have this risk. Patients that get 50 to 99 milligrams are at this risk, 20 to 49 of that risk. And you can see there's kind of an inflection point after that 50 milligrams where the dose starts going up a lot higher. And it gets a lot higher after about 100. So one thing I would point out about this again is everybody looks at this and they assume that this is a dose response curve and that this is the pharmaceutical effect of the opiates, right? This is opiate drug effect causing overdose. This is actually naturalistic data, and one of the things we know is that people who have a lot of risk factors right now tend to be the ones who are prescribed the most. So people who are on the highest doses are much, much more likely to be depressed, are much, much more likely to have substance use disorders than the people who are on lower doses. So this risk curve that you're seeing right here is a combination of the fact that we've been prescribing more to the people who are at greater risk, as well as the drug effects. Which explains some of the differences between what you get in models than here. So as I said, this is an exaggerated dose response curve based on dose, but what we need to do essentially is flip this around, right? Like get our high risk patients, and what I don't know if I put a slide, yeah. So what my pharmacy colleagues have recommended is just consciously trying to turn this around and say what we're going to do now, instead of just giving people more opiates as they have pain and they're not getting better, which leads to the people who are least likely to recover getting the most, which is the at-risk population, right? We're going to sit down, look at people's risk before we start, set a dose ceiling, and we're going to match that to the dose level. So if you have somebody with minimal risk factors, somebody who you're not really worried about, there's nothing suggesting that they're going to be bad, you say, okay, well, we will do a trial up to 90 milligrams and we're probably fine. And you may actually be able to go higher than that, but if it doesn't work by 90 milligrams, it's probably not going to work. For patients with moderate risk, you might want to cap it at 50 milligrams. And for patients at high risk, you can say we're going to do the opiate trial, but we're not going any higher than 20 milligrams morphine equivalent dose. And if you pre-plan it that way, then you basically catch things earlier, and you don't wind up with this backwards prescribing pattern of giving the highest risk patients the most. And I will say, so this is something people are playing with. Nobody's actually tried this, so I can't tell you for sure that taking this approach will lead to lower adverse events, but it certainly makes a lot more sense than what we're doing right now. Okay, next recommendation is that long-term opiate use often begins with treatment of acute pain. So when opiates are used for acute pain, you should prescribe the lowest effective dose of immediate release opiates and should prescribe no greater quantity than needed for the expected duration of pain severe enough to require opiates. 3 days or less will often be sufficient. More than 7 days will very rarely be needed. This idea here, you need to minimize days supply. You need to minimize, you need to pay attention to what you're doing even when you're prescribing for acute pain. Opiates no doubt about it, opiates are effective for acute pain. I don't think anybody would ever argue that at all. The problem is that a substantial proportion of people who start getting treatment for what's supposed to be an acute episode don't get off. So there's been a bunch of studies that have used surgery, receipt of surgery as a good marker for here's a time when somebody got a known injury, an injury where we can estimate the severity of it, and then tracked opiate use after that. And what they find is roughly of patients who had never tried opiates before they had the surgery, about 6% of the patients who started opiates were still on opiates as far as out as they looked. So, going on 6 months after surgery, they had never come off. And they probably, it wasn't likely they were coming off quick after that. What they found was that people who were on opiates before the surgery were very, very likely to stay on them after the surgery and not come off. That one, not particularly shocking. Once you've learned to use opiates, you're going to continue, whether your surgeon talks to you about it or not. Other things, though, that predicted whether or not the patient would come off after acute use was if the patient was depressed, they had much, much lower risk. It took them much, much longer to get off the opiate medication than if they weren't depressed, which would argue, addressing depression before people go into elective surgery, not a bad idea. Managing it after, probably smart as well. Interestingly, regardless of what their addiction history was, if the patient said they thought they were at higher risk of addiction, and they were more likely to stay on them longer. And I will say we actually thought that that was put in there because we thought it would work the other way, that people who were scared, because we got lots of people who we talked to who had a history of addiction or had family members who were addicted, who were terrified of their opiate medications, right? They didn't want to use them. They were really scared. It was like they will tell you it's the last thing they want. So we put it in there thinking that maybe that might be protective, and it actually worked the other way. So people who thought that they were at risk, they were. They knew themselves and they were in danger. So if you have anybody who says, I'm worried that I might not do so well on these, get them some extra help because they're probably right. But main point there is, again, when you're starting somebody even for acute use, there's a good chance they're not going to come off. And so you got to start planning right then and there. Okay, next recommendation, clinicians should evaluate benefits and harms with patients within 1 to 4 weeks of starting opiate therapy, or whenever you escalate dose. They should evaluate benefits and harms every 3 months or more frequently. And if the benefits don't outweigh the harms, they should optimize other therapies, so increase the other pain management treatment, and work with patients to taper opiates to lower dosage or taper and discontinue opiates. And so a couple things I want to highlight there. One, they're making strong recommendations for how frequent follow-up should be, which is something that hasn't been done in guidelines before. And one nice thing of having them in guidelines now is we find lots of managed care have kind of limits on how many visits their average primary care patient can have, and panel size practical restrictions on how often you can see patients. The nice part about this is if you have a guideline to back you up, you can potentially get patients in more or make arguments that you can't fit more people in your panel. Other thing to point out is when it says if it doesn't work, taper the patient, it doesn't say just that you should discontinue opiates. It says taper to lower dosages or discontinue therapy. So lots of people say, oh my goodness, this patient's at risk. Maybe they've been on opiates for 10 years. Somebody just started them on a medication they really need, and now they're looking all sedated and a mess, and they're not doing well. So you go, oh goodness, I can't leave them on the opiates. That's really dangerous. That doesn't mean you have to take them off completely. You might be able to taper them down to a lower dose where they're doing fine, they're functioning well, they're safe. and they may do a lot better. We do find there's lots of patients who actually they taper down and they function well at very low doses, but you taper them off completely and they struggle. And so zero is not necessarily required. You just need people safe. So I just emphasize the guidelines provide that wiggle room, which I think a lot of times people don't read into that. They just hear, take them off. So when do you discontinue? You want to obviously discontinue if it's not effective, when there's little improvement in pain severity or function within a safe dose range, when the risks outweigh the benefits, and that could include overdose risk, worsening pain or hyperalgesia if people just keep getting more and more sensitive, if you have a high dose with minimal effectiveness, or excessive side effects. And lastly, signs of abuse, diversion, or non-use. And so here, say if you've got somebody who's doctor shopping, using via inappropriate uses, so that routes, if they're smoking or snorting or injecting what you're giving them, that's a really bad sign. If they have an inability to quit despite consequences, I'd say all of those, you probably need to get them to substance use treatment sooner rather than later. The other part, the not taking the medication, I think there's lots of reasons for that, and that's something you should discuss with your patients. Obviously, do not give them more than they are taking because it does get diverted, it gets used by other people. Either, people who steal it, people who borrow it, people who the patient decides to give it to because it makes them feel better to help people. Like they saw how much their doctor enjoyed prescribing people their opiate medications, and they want to give somebody, they want to help too. I think I would the not using part, you gotta talk to people and you gotta minimize what you're giving people. If you're going to taper someone, you're going to take them off, you want to decrease dose gradually. You can, if you think the patient's at risk, obviously taper as fast as you need to get them safe. But the longer they've been on treatment, the slower you should probably go with the taper, right? So they're going to have adapted more. It's going to take them longer to adapt back. So taper them slow if they've been on the medications for a long period of time. The other big piece is talk to your patient, right? Different patients will be able to tolerate more rapid tapers than others. There is no one standard for appropriate tapered rate at all. You've got to pay attention you got to talk to your patient, taper it so that they're not uncomfortable and they're able to handle it, or you're not going to succeed because they're going to run to another doctor, and two, you're leaving them vulnerable. They're going to take whatever's left in their bottle if they feel like you're tapering them down too much. So recommended rates, they vary a huge amount. So I've tried to look across to find some standardized taper rates for you. They're all over the map depending on what guideline you read. So I'm going to suggest something in the range of 10 to 25% reduction every 1 to 4 weeks. It's on the conservative side, but will work for most patients. You can do it more quickly and with greater percent chance if the risk is greater. If you have somebody who's very high risk and you think you need to do a really fast taper and you don't think they're going to handle it well, you might want to consider inpatient treatment just to keep them safe. While you are tapering the patient, you should also be treating their withdrawal symptoms. One thing I emphasize is opiate discontinuation should always be to reduce risk or improve function or improve pain management. It's not a punishment. Even if you're really, really mad at your patient, right? Like even if you found that he was lying to you and he got a bunch of medication, he was doing illegal things with what you were giving to you, or somebody got hurt with the medication that you gave him, It's not your job to punish them. There's law enforcement for that. Healthcare should not be doing it. And even though you could kind of torture them by playing with your taper schedule and not treating their symptoms, don't do it. That's not your job. So opiate discontinuation should never feel like a punishment to your patient, or it's not going to be good for Treatment Alliance. It's going to make it really, really difficult for you to work effectively with the patient to get them better. So that being said, and this is not being accusatory, I just see it happen. This is how, even if it's not intended, that's what the patients think you're doing if you're not careful. So make sure, screen for withdrawal symptoms, and you want to treat them in general. So general withdrawal, the best general treatment for withdrawal symptoms is clonidine. Dosing recommendations are right on your slides. It has good general effects for reducing most of the symptoms of withdrawal, but doesn't work quite as well for anxiety, restlessness, insomnia, and the like. You can add hydroxyzine for anxiety, dysphoria, tearing, and runny nose, if that's something your patient's struggling with. You should use NSAIDs or acetaminophen to help with muscle pains and other problems that they may experience with withdrawal. For sleep problems, so a lot of patients are going to struggle to sleep during this, and I know lack of sleep amplifies pain really strongly. So if you have somebody who's not sleeping well, their pain is going to go through the roof. You want to get them sleeping. Trazodone or gabapentin are probably the most recommended treatments for use during withdrawal. You should pay attention to nausea and diarrhea, treat those as you need to. I will note that opiate withdrawal can be pretty substantially, it can be problematic. I mean, if you do it too quick, just to give you a sense, I used to do withdrawal studies in rodents. They would lose 30% of their body weight in a couple hours if you tapered them too fast. It's a lot. The diarrhea is not a minimal thing. So pay attention to it, screen for it. I know it's not fun to talk about, but make sure the patient's treated, because dehydration is probably actually the thing that the patient's most risk for during withdrawal. This is one of the disturbing graphs from our current epidemiology. So you can see that over the last few years, that purple line, the number of opiate overdose deaths has stabilized. So great, right? You look at that, you're like, good, we're doing good, we're starting to come down. But at the same time that started stabilizing, the heroin overdose rate started shooting up really, really quickly. And so what it seems is happening is, as patients are getting discontinued off of their opiate medications, people are paying attention and going, you're not doing well, I think maybe you're misusing your medications or you're abusing your medications. They're taking them off and they are turning to heroin because heroin's readily available. In some cases, it's cheaper than prescription meds. So people who either can't afford the prescription meds lose their insurance or get taken off and no one will prescribe to them anymore for one reason, are turning to heroin, and that's, again, not helping anything. So point I would make there is you're not just trying to get the patient safe from the things that you're giving them. You're trying to get them safe overall. So it's incredibly important that you don't abandon your patients when opiate therapy fails. So they are going to take it, unless you are very, very careful about how you talk to your patient and you make sure that you're working with them on pain management and that you do the taper collaboratively, they're going to feel like you're punishing them if you're not careful. And the main thing that punishment does is it causes avoidance of the punisher. And if you're the punisher, they're going to leave. They're not going to come back to you, and they're not going to come back to the healthcare system. And we know from that last graph that they don't do any better. They're not any safer if they run to the street for their pain treatments or to treat their opiate addiction. So